Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the presentation. It is now my pleasure to turn the conference over to Chris Hund.
Thanks, Stephanie. Hi, everybody. Welcome to the monthly webinar here in September. Thanks for attending. This is Chris Hund. I am the director of the AHA Team Training Program and a director with the American Hospital Association Center for Health Innovation. So thanks for joining us. I think we've got a great webinar lined up for you here today. So just a couple rules of engagement for everybody. You can listen to the audio for this two different ways. You could do so through the phone, and if you do that, please mute your computer speakers, otherwise you'll get some really weird feedback. Or, of course, you could do it through your computer. The way to mute is there's a little button at the top of the meeting bar that if it's green right now, you're going to want to click on the arrow next to it to take it to mute my speakers. We'll do a Q&A session at the end of the presentation, but please chat in questions as we go along in that chat box. We'll try to answer them as we go, or if they seem to be a question that's really good for everybody to hear, we'll hold it and then I'll bring it up with the speakers at the very end. So a couple of announcements. Just announced yesterday, really, is our conference for next year. So we are headed for our yearly annual national conference to San Antonio, Texas. So we will be at San Antonio June 12th through 14th. We hope you're excited. We hope to see you there. It's a great event. We'll be sharing more information in the coming months as the year winds down, but the first thing that will come out is a call for proposals. So we will be asking for all of you to submit something that you may want to present in a presentation or as a pre-conference workshop or as a poster. And the great thing about this conference is that it's very, very much driven by the community. It's always folks that have come through team training courses and are excited to share how they've surmounted some of their challenges or how they've gone and done their work. So please keep it as a possibility on your calendar. We also have our first specialty course coming up of the year. This is a course called Gaming in TeamSTEPPS, Where to Begin. And so, if you look at the picture there, if you want to stand with a blindfold on for a day, come to our course. But this is a really fun course that's being put on by our colleagues at Nemours Children's Hospital in Orlando, Florida. They have had a very, very popular conference workshop during the course of the conference for the past 3 years. And so they've expanded it, added some things in, and are going to do a day-long course in Orlando. So it's a lot of fun. I think that you'll really enjoy it if you get to go. They're a great group, and they'll really help you understand different ways to facilitate team steps with your teams at hospitals. How can you teach people or refresh their skills, really work on the behavior change elements of team steps through gaming? So fun course. If you're interested, there's a link here to register, but you could also head on over to the AHA Team Training website to find out more about it. We have some master training courses coming up as well very soon, September 20th and 21st in Centennial, Colorado, which is just outside of Denver. Our team from the University of Washington is going to hold a master training course. So there's still some slots available there. So if you want to go to Denver or if you're in the Mountain West area, it's a really great opportunity. None of the regional training centers are in that area, so we're bringing a regional training center to you. So a great opportunity to get with some of our long-term faculty that have been doing this for close to a decade coming to you in the Denver area. We also have courses in October 4th and 5th in Cleveland, Ohio with the MetroHealth Team. who's going to be giving this webinar right now. So if you like the webinar and you want to learn more, you can go over to Metro for a course, as well as courses at Duke and at Tulane University in New Orleans. Our next webinar is October 10th, and it's from folks at UNC Health. It's Optimizing Tar Heel Trauma Care, Hardwiring TeamSTEPPS into Trauma Resuscitation. So that registration is coming really soon. As always, you can give us email or give us a call at the number on the screen, or head over to aha.org/teamtraining. So without further ado, I'm excited to have our presenters here today from MetroHealth. MetroHealth is a regional training center of AHA Team Training and has been involved for many years with the TeamSTEPPS work that we've done, and they've really been stars at what they've done, and I'm glad to have them here today to talk a little bit about their journey. We've got Annie Alucio, who's the Patient Safety Officer, Anne Fiorta, who's in the Medical Step-Down Unit, Joseph Carvan in Radiology, and Dr. Robert Smith, who's the Director of the Medical Staff Assistance Program and also directs the TeamSTEPPS work there. So I think I'm tossing it over to Dr. Smith.
Thanks, Chris. So hello, everyone. I want to thank AHA for allowing us this opportunity to share our journey with TeamSTEPPS. Sort of to set the stage, what I'll do is I'll tell you a little bit about MetroHealth. So MetroHealth is a public institution in Cleveland, Ohio, and we basically serve Cuyahoga County, and we've done that for over 180 years. We're a level 1 trauma. We're also a burn center and a level 3 NICU. And we're the academic medical center for Case Western Reserve University School of Medicine. So all of the attendings and everyone who works here are faculty with Case Western Reserve. So we're a mid-level sort of organization. Whoops, sorry about that. Oh, there we go. When you think about our organization, we're over $1 billion in operating revenue and about a little over 1 million in ambulatory visits and over 125,000 emergency department visits. Our entire staff is somewhat over 7,500 employees, and if you take a look at our network, we keep growing. We have a large ambulatory network that, that includes 23 health centers. We've got 2 micro hospitals now and 3 community emergency departments. So our journey with TeamSTEPPS started in 2013, and so over the last 5.5 years, we've worked to both implement and sustain our TeamSTEPPS program. In the beginning, what we started with was we sort of took a traditional approach. We had identified a champion. We established a TeamSTEPPS change team, and that group then approached our leadership. We wanted to determine what their buy-in was going to be for this initiative because we knew we were going to need staff to have time out of work. We knew that we were going to need some resources, and we wanted to make sure that they were on board. And fortunate for us, they were on board. So 2 key decisions were made right up front. One, we were going to use the train-the-trainer model. So we were going to have master trainers who would train instructors, and then the instructors would train all of our staff. And so we prepared a group of master trainers. Now that group has grown to over 30. We developed a steering committee that would guide all of our steps as we moved forward, and we made a very important decision. We decided that we would implement TeamSTEPPS system-wide, meaning that both our clinical and our non-clinical staff would be trained in all the fundamentals of TeamSTEPPS and would participate in our sustainability as we moved forward. So we developed our instructor training course. We allowed all of our instructors to modify that course so that it was specific to the area where they worked, and we began our implementation. Again, that was 5.5 years ago. Our organizational change team was key in making this happen. As you can see, it was very diverse, and it included a number of strategic partners: organizational development, our simulation center, communication and marketing, diversity and inclusion, and very important, our union. So the goal was to have people on the change team who would take away barriers as we moved forward and would help us be able to reach all of the staff, including the physicians, because we knew that as we moved forward, without the physicians, this initiative would fail. As an indication of our leadership support, you can see that they were modifying our mission statement and our values at the time that we were beginning TeamSTEPPS. And we were able to get them to integrate teamwork into both. So our mission statement, leading the way to a healthier you and a healthier community through service, teaching, discovery, and teamwork. So this was not just a concept that we were discussing, but now it was becoming part of our culture. As you can see in our core values, which we call STAR IQ, again, service to others, teamwork, accountability, respect, inclusion, and diversity, and quest for excellence. Again, weaving teamwork into our very fabric of who we are as an organization. So once we got through the implementation, the key was, how do we get people to continue using the TeamSTEPPS tools and strategies and not have it fade away? And so I'm going to pass it over now to Annie Alicio, and Annie's going to talk about our sustainability.
Thank you very much, Dr. Smith. So as part of our sustainability plan, we decided to create TeamSTEPPS Action Councils. When a department was completing their training, the master trainers would meet with managers in the area to identify employees that had an interest in TeamSTEPPS. We would post a call to join the TeamSTEPPS Action Council, and then the master trainers would attend the first meeting to explain what our intention was and to really get the interest and the excitement going. We shared our goals, so we gave them 4 goals. We want you to think about projects that improve patient safety, improving patient satisfaction, employee safety and satisfaction, get the employees engaged, and also to think about improving processes and efficiencies. We encouraged them to start with very small projects so that they could see that TeamSTEPPS works, and that really helped to get the momentum going in those areas. Some areas were very energetic and they wanted to take on a huge project from the beginning. How can we keep people, change the scheduling templates? And that was way, way too big. So we encouraged them to start with small projects and then work up the momentum to the bigger projects. It's hard to find. So the structure of the Action Councils. The Action Councils have 2 chair people, and these are not to be part of leadership. We wanted frontline staff. We want the grassroots problems that frontline staff are facing every day to be brought to the Action Councils. And then we assigned a master trainer to sit on each council. The master trainer joins from the very beginning and helps these new chairs with the logistics of forming a committee. Frontline staff typically do not have that type of experience. So we're helping them to set up the meetings, create invitations so that they'll populate employees' calendars, advertising for the employees that don't typically use an email calendar. How are we going to post this in the various areas? Helping them to secure a room for the Action Council meetings, creating an agenda, assigning someone at the meeting to take minutes, coach them on how to run a meeting, and then we would sit right with them when the first meetings occurred and help them really every step of the way. We also encourage them to find ways to share the progress with their departments, because people want to know what is happening with TeamSTEPPS, and definitely to share that progress with the leaders. The leaders have invested time and their resources to help train their employees, and we need to let them know that the improvements are sustaining. So we asked them to choose one person from every discipline or job category that works in that unit. And we want them to choose an alternate because we wanted each job category to be represented at each meeting. Our environmental services staff attends the meetings, nutrition, pharmacy, nurses, physicians, social workers, every discipline that works on the unit, the desk staff, everyone has input. We also created a sustainability committee, And these are the master trainers that are on the action councils. And we would meet monthly and we would review the projects and any issues or barriers that would come up. And as we grew and developed more and more action councils, we had a little trouble managing all of this in an hour meeting. So what we did was we came up with an idea to have a huddle. We have a daily safety brief in our hospital that occurs in the morning where 25 departments report out on any safety issues that have occurred in the past 24 hours and any safety issues moving forward. We took that model and we created a TeamSTEPPS Action Council briefing. So once a month, we just began this recently. We do have the Action Councils calling in, and we want them to share their current projects and any barriers they're having, and then we will try to assist them with their barriers. But also part of the Action Council itself, we have an administrator that serves on the council, and typically it's an administrator from that area. That administrator's role is to be a silent participant and to only address barriers when they come up. So that has also helped as well. After the Action Councils are functioning for about 4 to 6 months, we will include a patient and family advisor. This is from our Office of Patient Experience. So these are patients and family members that volunteer in our hospital and they want to become involved, and we've asked them to join the Action Councils. They've had wonderful input as the patients entering our system, noticing things that affect perhaps their privacy or how we could make their experience better. So they have had excellent input coming into our Action Councils. Next, I want to give you some examples from, we have 2 of our co-chairs from Action Councils in our hospital, and this is going to be very exciting to explain their journey with their TeamSTEPPS Action Councils. So I'll pass this to Joe Carbon next.
Hello everybody, my name is Joe Carbon. I'm from the Radiology TeamSTEPPS Action Council here at the hospital. One of the things I wanted to touch on before I even get into the presentation itself is one of the benefits of this program is that it's giving administrators a perspective that they normally wouldn't be able to see from frontline staff. And with that perspective also comes some empowerment for frontline staff. If they feel like they're able to make a change, it increases engagement and increases satisfaction for not only themselves but also the patients. So we've seen that pretty apparent in our TAC that's been together for a little over a year now.
Take it up high, Joe. We lost our mouse. Hold on.
Bear with us one moment.
I was there just a second ago. I'm just going to move it forward.
Yeah, that sounds good. Okay, so one of the major things that probably a lot of departments will find as a barrier to implementing this program is that they feel like they don't have enough time to do this. I'm here to say that you absolutely do have enough time to do this. It is possible. Radiology is made up of a 24/7, 365-day-a-year department. We have various shifts. We go overnights. We have weekends. We have holidays. We have a mix of clinical and non-clinical staff. And the other barrier is that we have full-time, part-time, and PRN designations. So people aren't always here working. So what we found that we had to do was we had to address this issue in order to get the tools to each of the individuals in our department. So what we did was during our program development, we separated each of the various tools into a different process on a month-to-month basis. So we taught 10 courses per month at various times and days to allow for all 3 shifts to attend. The first month we did the introduction to TeamSTEPPS, what the program was, what our intention was with the program, and we also added a leadership aspect into that course. That kind of went over the effective team leaders, some tools like brief, huddle, debrief, things that the staff could take back immediately and start implementing in their areas. After that, we followed up with communication like SBAR and handoff. and then so on and so forth on a mutual support, situational monitoring, and then the actual TAC development. We had to spread out each of these individual tools to reach all of our staff members, but we were able to do it, and we made it a requirement that each of the staff members were able to attend, and that they had to come and attend one per month. So supervisors and managers were the ones that were going to be responsible for assigning the staff members, because basically at the end of the day, they know their departments better than we do. We wouldn't be able to sit and decide, okay, we're going to have 4 people from MRI today, we're going to have 2 from CT. That it wouldn't work that way. So what we were then able to do is we wanted to have 2 members from radiology teach each course, and that way they can kind of piggyback on one another and create more of an environment where it's more conversation, more examples, and less strict teaching. We try to bring in activities, videos, and have real conversations in our classes. We talked about actual real-world issues that we were facing at that time in radiology, and how we may be able to address those with TeamSTEPPS tools. And when we were developing the curriculum, we tried to give the paired instructors freedom. We wanted to allow them to pull their own perspectives into the class. When I was teaching courses, I wanted to bring real-world examples from my own life. I wanted to bring examples that I had seen in my profession. And every class was different, and every class was able to kind of touch on something that people could relate to. So during the TAC development, after we had done actually rolling out all 4 months of the courses and teaching the courses, we went over the program in detail, and we basically reached out to everybody that had come to the courses and looked to see if there was any interest in joining the TAC. And the idea was that we wanted to have a representative from each area of radiology. And radiology is a big department, so we had nursing, CT, scheduling, physicians, ambulatory X-ray, interventional, MRI, so on and so forth. So, but what we also wanted to do was we didn't want this to be strict. We wanted to have an open door policy. We wanted different members from different areas to be able to attend. We wanted replacements there if a member could not attend. And this was eventually going to help with burnout. It allowed for people to bring new, fresh perspectives in and made sure that not too many responsibilities were falling on the individual assigned to the TAC. So we also, as Annie had mentioned in her area of the presentation, the TAC was filled out with other members from the organization as well, including patient family advisors, Office of Patient Experience representatives, and a TeamSTEPPS master trainer. So our TAC, what we found works the best is we meet once per month for roughly an hour. Sometimes it goes a little bit longer than that, but we come with an agenda, and we try to tackle all of the things on the agenda, but also leave time at the end to kind of circle back around and see if there's any new challenges that people are facing, any concerns that anybody else may have seen or that has been brought to that person coming to the TAC from their modality or from a patient that we can try to address. So early on when we were first developing and rolling out our TAC, we focused on kind of giving an open door or open mic and allowing everybody to kind of bring up an issue that they have seen and create a conversation and see how realistically we were going to be able to address that concern. When we first started out, there was big project ideas. There was some very, very big project ideas, and we kind of felt that maybe it would be best if we try to tackle smaller things, more achievable things first, to kind of establish a climate that we could make changes and could make things happen. You know, it's like the little victories type of thing. So once we were able to kind of get the ball rolling and accomplishing some projects, then we were able to move on to big things. You know, we did have a mix of big and small, but mainly at the beginning, the first 4 to 6 months, there were smaller projects. So as I said, we've been meeting for once per month for over a year now. We've had a lot of success with our projects, but there has been also many, many barriers on some of these projects. However, the good part about that is that when we found a barrier, we haven't given up on the project. Instead, we've steered the project into another more achievable direction so that we can still have a similar outcome. And, you know, just focusing on patient satisfaction, patient safety, employee satisfaction, and engagement, we've been able to do a lot of really good things in our department. The tools that were taught by TeamSTEPPS allowed us to not only voice our concerns, but also to come up with solutions. One of the things that I liked to do in my meetings was introduce the debrief tool at the end. And the reason is because we didn't want to leave a meeting without a plan on how to address an issue that came up. Before the TeamSTEPPS program, I can't tell you how many meetings I had gone to that ended, without a debrief, and you left the meeting and thought back after the fact and said, did we actually accomplish anything there? So this was a good way to kind of say, all right, how are we going to tackle these projects and these issues that we brought up today? We don't have to come up with a solution today, but maybe we come up with a plan to get to a solution down the road. So the TAC has been able to work with a lot of other areas in the hospital and able to touch so many different areas of the organization. Now, some of these areas that we worked with were smaller end projects where maybe we just addressed a really, really tiny concern, small change, whatever it may have been, but it developed a relationship with those areas, and it laid the groundwork for future projects because we all had the shared goal of patient satisfaction and efficiency and employee satisfaction and safety. So if some of these areas that we worked with, if we didn't have these big groundbreaking projects that we completed, we were able to at least establish that relationship where we can come back around and have a rapport together and try to tackle something that we saw needed to be fixed. So we've had a ton of different project examples. I'm not going to go over each and every one of these, but I just want to present these as an example of how big and how small some of these things can be. Point of care testing was a huge size project that actually didn't even end up with point of care testing. It was one of those things that faced barriers that we were able to morph into a different project with the same outcome. Patient satisfaction surveys that we did, we added providers and contact information, provided masks. We did a lot of things like that that were smaller that were able to lead to other things and to help us accomplish other goals. Again, some other project examples here, changing reminder message process for patients. Patients coming in confused because they didn't know the time of their appointments, their instruction for their appointments, where to check in, little things like this that go a long way for patient satisfaction. And providing phone charges in high volume patient waiting areas. Another small project that we were able to do, that we were able to provide patients with a service that may seem silly, but it actually went a long way for patients and family members that are waiting for hours for these long, in-depth exams in radiology. One of the big projects that we worked on and that we're continuing to work on is with the Department of Transportation, and radiology is one of the biggest users of this department in the hospital. Basically what was happening is we were seeing increased wait times for patient transportation during certain peak hours of the day. So what we did was we invited members from the Department of Logistics and the Department of Patient Transportation to a TAC meeting to kind of address these concerns. And prior to the meeting, we wanted to make sure that we were prepared where we not only were voicing the concerns, but coming up with potential solutions. So we worked with information systems to pull some data on transport. We did it over a 2-month period in November and December to determine when the usage times were the highest for radiology and when the wait times were increasing above average. So we had a solution-focused discussion. There was no finger pointing. We were able to sit down and we were able to come up with some solutions on how to fix this issue that we saw in radiology. And it led to the development of a really great zoning program that we started to utilize within EPIC, which is our charting system for the hospital. And it was able to kind of zone transporters to areas of radiology to keep them closer so that they were tackling those first before going too far across our pretty big hospital here. It limited the distance traveled, which eventually would increase efficiency. And as I said, we created an electronic transport request system. So instead of calling floors, talking to secretaries on the floors and facing issues with handoff or whatever other concern, we were able to do that electronically to kind of bypass that and to reduce any errors down the line. So with our TAC, we've been able to sustain it really well because we've limited the amount of members that have turned over, but we've also kept that open door policy and allowed other members to come in and new fresh ideas to come and kind of get into our TAC and allow us to create some new projects and new perspectives that we normally wouldn't have been able to do. and we've kept members engaged, and I don't want to say by assigning so much, but by feeling the room out and finding out what they would be passionate about doing. That's kept people really enjoying our TAC, and as I had mentioned before, when we face barriers, we haven't given up. So we've been successful because of those things, but also because we have buy-in from our administration as well. So what has happened then since we implemented this program is we do a debrief with our administrator in radiology probably once every other month, and we go over kind of some of the projects we're working on, and they're able to kind of assist us with those things to help reduce the barriers that we may see, but also keep us on track so that we're addressing things that are plausible. So we don't just always focus on what's wrong in radiology. We try to work on other engagement projects such as Tech Week. We try to make members feel like they can come and make a difference and institute positive change, because as I mentioned at the beginning of my presentation, when people feel like they can actually make a difference, it goes a long way to employee satisfaction and eventually patient satisfaction. I'm going to hand this over to Ann Fiorta, and I thank you all for your time.
Thanks, Joe. This is Ann Fiorta, clinical nurse in the medical step-down unit and also the co-chair of the Pulmonary Medical Step-Down TAC. There it is. Okay, so when the organization adopted the TeamSTEPPS model and decided that all employees were to be trained, staff volunteered to become instructors and took TeamSTEPPS tools and concepts to the employees at the department level. We had instructors from many disciplines, including respiratory therapy, nursing, medicine, and supportive clinical staff. And as a group, we decided to offer training sessions somewhat like radiology offered in 1-hour increments covering the different concepts such as communication, leadership, mutual support, and situational monitoring. We offered various times across different days to accommodate staff on all shifts, and it took about 4 months to complete the training. Once the training was completed, the next step was the development of the Action Council. And for the Pulmonary Medical Step-Down Unit, we had really early physician buy-in with our medical director becoming part of the team, both as an instructor and as our administrator. For the rest of our TAC, we sent out emails inviting people to attend, and we got an overwhelming response back from both respiratory therapy, our pulmonary physician group, nursing, nutrition, pharmacy, and clinical support staff as well. So, as I just mentioned, it's multidisciplinary representation from nursing, medicine, nutrition, and support staff, and pharmacy and respiratory therapy. It's all voluntary membership, and it's an open-door policy, and we've had pretty much retention of our original members since the time we began meeting December of 2017. For our first meeting, we decided in response to some critical incidents that were reviewed that we would brainstorm to identify issues that we could begin to work on as a group. We used multi-voting to determine what our first project would be, and interdisciplinary communication received the most votes, and it was overwhelmingly decided upon that that would be what we would address first. We looked at many barriers to communication throughout our unit and department, and interdisciplinary team rounds was a project that we decided to focus on, and that was our pilot project. So we looked at the steps that we used to decide on this pilot. We looked at critical incidences that occurred in the area, barriers to rounds that we had identified, and inconsistencies in communication between physicians and nurses were identified. And even though this is multidisciplinary, and it seems that we're just looking at physicians and nurses, we had a lot of input from other staff that was present, including respiratory, secretary staff, and our support staff as well. Everybody was able to give some input, almost like a lens they're looking from the outside in. And then we decided to develop a checklist to guide our nurses into providing clear and concise, focused information during rounds. So initially, we looked at some of the challenges we were going to have in this pilot program. And on the physician end of things, some of our challenges were attitude of some of the physicians towards multidisciplinary rounding. Being a teaching hospital, timing of rounds is not always consistent, and it's very much provider dependent. Throughput is also involved in this, like we need to get patients in and out, move through the organization, and there's teaching responsibilities during rounds. So some of the solutions that we came up with as a group is we had an early on physician champion who encouraged his peers to participate and make meaningful change. Our department chair, who is our administrator, supported the project, and nurses worked to provide a focused report, and we did this in collaboration with the physicians present on our team. We decided as a group what is the most meaningful interaction during that multidisciplinary round at the bedside with the patient to affect good patient care. And we also decided upon an improved process to call nurses to the bedside to reduce any delay in rounding. On the nursing side, some of the challenges are concise and focused information that's provided during that interaction at the bedside. And this is a unit that has a greater percentage of nurses with less than 2 years experience, so it's a fairly young nursing staff. With that comes anxiety sometimes of presenting in front of a group of providers, and some fear that they're not going to give the right information. And then once again, timing of rounds and interruptions. So patient care has to continue during this time. There's procedures, there's patient care items that need to happen. So inconsistency with timing of rounds can actually lead to some interruptions. So solutions that were discussed, we're coming up with a topical outline for rounds, something that's formatted and it's consistent and every nurse presents the same information in the same way. Education of our newer nurses by the senior nurses, and offering a mentorship and sort of support for encouraging them to give that information. And then fostering attitudinal change in nursing and in their participation in team rounds and in the importance of it in patient safety and patient care. So what you can see on the screen now is the template we came up with for the information that would be presented, and we use the mnemonic smiling, and as it says there, just lists the different areas that the physicians and nurses felt were important to be communicated during each and every interaction for each patient daily, so that we knew that what the plan of care would be. So during the implementation, the nurses were given the information on the mnemonic of smiling, and they received a pocket card to carry with them. Our residents are given a weekly orientation on unit-specific guidelines, and this includes the appropriateness of admissions, the type of patients, and the routine care of the patients that come to the step-down unit. Each day, the attending or the senior resident is given an assignment sheet that lists the patient and the nurses that are assigned to that patient, so that there's not a barrier to being able to call the assigned nurse to the bedside during rounds. And then when the nurse is called, they're able to provide that focused information, and that exchange of information leads to dialogue and update on the plan of care. So the process has been implemented. It's being utilized daily. We have developed a questionnaire to obtain feedback from physicians and nurses to see what works well, what doesn't work well, should we make modifications, and it's an ongoing process. And we have future plans to incorporate multidisciplinary simulation to educate and reinforce the multidisciplinary rounding process. And this will be done with a patient-based scenario where we will go through the process of how calling the nurse to the bedside, what information is given back and forth, and then there should be a call out and a check back at the end of that interaction to verify that everybody has received and heard the same thing. And then our TAC has an ongoing commitment to the TeamSTEPPS process. We continue to meet monthly. We always revisit at the beginning of each meeting all the ongoing projects that we have and give updates on progress, and we continue to brainstorm for new ideas.
Okay, that's what we have to present. Chris?
Thanks, guys. Thank all four of you. Really appreciate it. We have some really good questions here. Some of them kind of be put in two different categories. There's questions specifically about the TACs, and then questions a little bit more about your overall process of getting people trained and such. And so I feel like let's talk about those training-related ones first, since we do have a good 20 minutes, since kind of chronologically people go through training first before the TACs are created. So does that sound good to you?
Yes.
All right, cool. So when you're just thinking about the general way that Metro goes about training people, when you think back to the start, how many people did you have kind of as your original group of trainers, your original, core team that kicked everything off?
Our original group was relatively small, so we had probably about 6 master trainers at the very beginning, and our intent was not to train the whole organization in a short period of time. I can still remember when our CEO asked me how long this would take, and I paused for a minute and I said yes. And then he looked at me and he said, "You're not going to answer my question?" And I said, "Yes." And he laughed a little bit and he said, "So explain how this is going to work." And I said, "We really don't have a timeline for rolling this out. If we're going to create a change in culture, we don't want to just shove through a training program." So our intent was to identify individual areas, divisions, departments, and work with them one at a time. And it's taken us nearly 4.5, 5 years to train the entire organization. And leadership was okay with that. Our master trainer group grew as we moved forward, and our instructors were selected from every area as we began to plan training. So our first areas were the emergency department, OR, PACU, and our ICUs. They were all eager and wanted to do it first, and so we picked just one area, the ED. We identified staff who were willing to be instructors from that area. We trained them, and then we gave them a template of a curriculum which was about 4 hours long that they then made their own. They added videos, they added activities, they changed some of the slides so that it was relevant to the ED. And then we supported them and coached them as master trainers, but they did the actual classes where they trained all of their staff. And that's very time consuming because you can't take all the staff out of service so that they can go through a class. We would do it with classes of 10 to 15 at a time until a department was done. And then we would move from that point where everyone's trained to forming their TeamSTEPPS Action Council.
Thanks. Thanks, Bob. So when you go past that period of time when people have been trained and you've created your instructors, do you have coaches? Do you use coaches on the units in a long-term kind of fashion? Are they there, or are they part of the action councils? How do you go about with that reinforcement?
So the instructors really are coaches, and there's sort of two hats that they wear. So when the training is going on, they do the teaching, but when the teaching is done, they now are the sort of on-site experts regarding TeamSTEPPS and become the coaches. The master trainers are also still involved with the TAC and provide coaching for the chairs and for that council. And so everyone who's been trained as an instructor is sort of dubbed as a coach to help keep it going and reinforce and encourage people to use the tools.
Got it. Can you remind us again the length of both the master training course that you provide and then also your course for your instructors, and then, you know, about how much time those instructors spend then teaching?
So the master trainers go through a full day of training. It's 8 hours, and we go through all the fundamentals, but then we also focus on how to teach, how to coach, and how we're going to create this change in culture. So they're learning not just the fundamentals, but how they're going to help take our organization and move this forward. The instructor course is also a day long. We train the instructors, and they then do a 4-hour course for all their employees. Now that 4-hour course, we let each area or division decide how they want to do that. They may do it as a 4-hour course, and they have 10 to 15 people come in and go through 4 hours of training, or they may break it into 1-hour segments, or a 2-hour and another 2-hour. We let them sort of decide how they want to do that because we want them to be flexible. I don't want to pretend that I know what's the best way for the OR to do their training. They know their schedules, they know their staff, they know what will work. So we support them, but we don't dictate. They decide, and we support them in implementing.
Got it. Yeah, so that really kind of goes, there was a question here about what kind of upfront planning and investments, you know, do you do, like numbers of staff, you know, time and resources. And it really sounds like once you get to that stage of working individually at the departments, it's up to them to take ownership about what kind of investment they're going to make when it comes to how they're going to do the training, what resources they need, both human and otherwise.
Right, but we really help them with that, because the first thing that I will do when we go into a department is go meet with the chair and make sure that the chairperson understands that we would now like to do this training within their department, and we determine readiness. A department may not be ready. If they've got 4 or 5 major initiatives going on, renovation of Epic, or they're, changing all of their equipment in their area, they may not be able to do TeamSTEPPS at the same time. So we determine their readiness. We make sure that the chairperson understands the commitment. And the major commitment is time away from work. We're really not asking for a lot of overtime or extra from the department, but we are asking that they set aside time for each employee to step away from their daily work and participate in the TeamSTEPPS classes.
So people are not compensated extra, it's a part of their normal daily work to attend this.
That's right. We try to make it part of their daily routine so that they're not putting in extra time. Now, we did in one of our areas, because of the scheduling and them being somewhat short-staffed, we were able to get our CNO to agree to pay overtime to nurses to come a little early or to stay late to participate in the TeamSTEPPS training. So that was a huge investment by our organization, and our chief nursing officer supported that.
That's great. How do you involve and motivate your physicians? I mean, I know that there are some really powerful physicians that are on your team that are probably great cheerleaders and people that help others take ownership, but how do you motivate them? How do you get them going?
It's not easy. I think that I'll answer this, and then I'll let Joe and Ann talk about their areas. But one of the things we do right from the beginning is we tell the departments, this is not a nursing initiative. This is not an educational initiative. This is a culture change, and everyone must be involved. I still will remember the first time I made the pitch to the OR and PACU staff. It was a 7 a.m. meeting. I just had explained all about TeamSTEPPS and how it was going to work, and everybody seemed very supportive. My presentation was done. I'm leaving the auditorium, and a group of about 20 nurses stopped me. And they said, we just have one question. I said, sure, what's your question? They go, tell us the surgeons are going to be involved. or we don't want to bother doing this. It's a waste of our time. And when I reassured them that surgeons were not only involved, but were going to be instructors, there was a sigh of relief. And I think very early along with each department, as you work with them, you have to identify the physicians almost first before you go too far along. So let me let Joe and Ann talk a little bit.
So on our TAC and during our development, we had physicians that were instructors. And then after the 4 months of training that we did with the TeamSTEPPS training, the biggest issue I had was trying to find somebody that, a physician that felt that they had enough time to sit on the TAC. And we were able to do that, and they've been engaged, and they've been able to bring issues to the TAC that they feel their colleagues are also facing and try to address those. And it's been able to create much more buy-in for it. As far as attending the courses, it was a requirement, so every staff member in radiology was there. And you know, the tools spoke for themselves. It wasn't, we weren't reinventing the wheel, but we also were teaching some things that were going to keep patients safe and keep employees satisfied and patients satisfied. So once they saw the lessons and heard the discussion, it was pretty easy to get them engaged after that.
On the pulmonary, medical, and ICU side of things, it was very similar. We had buy-in from our physicians because they were also instructors, one being the department chair, which helped tremendously, and he also sits on our TAC as an administrator. And we have a very wonderful physician champion who takes many of the things that come up in our TAC back to his peer group, and he's very supportive of everything that comes out of our TAC. In addition, we had secretarial staff, and part of that secretarial staff was the physician secretaries, and they would assign themselves to the same teaching block as the physicians, and they would come together. It worked, and it worked well. Yeah.
Thank you. So a couple questions before I want to talk about the TACs a little bit, but Bob, there have been a couple questions about if you're using a specific tool to determine readiness or how you're going about doing it. And yeah, as somebody commented, there are some readiness tools that are available on the TeamSTEPPS webpage through AHRQ, but I didn't know if you were doing something specifically.
We don't have a written tool as much as we use several steps as a way of gauging their readiness. So the first meeting with the chair, if I see that the chair is very supportive and receptive, that's first check mark, a good thing. If I hear that the chair is not going to be supportive, it really doesn't matter what the rest of the department wants to do. If I'm not going to have the support of the chair, it really doesn't pay to move forward. If I have the support of the chair, then the next thing is we do a presentation to the staff in general during one of their staff meetings, and we do an AHRQ survey. When we look at their response during that meeting, we can also get a gauge of how many people are willing to be instructors. If no one's volunteering, that's a concern. Yeah. If we have very little return on the AHRQ, or the AHRQ surveys indicate that the morale of the staff is extremely low, we may need to do resilience training with that area before we begin talking about TeamSTEPPS. So I think rather than using an instrument alone, what we're doing is trying to gauge the actual investment and receptivity of the chair and the staff, and particularly the physicians.
Got it. Thanks. So with your TACs, there's a couple questions that people had, mostly about structure. So I know you touched on this a little bit, but can you talk a little bit about how the TACs report back? Who are they reporting back to, or what structure are they reporting back to? And is it somehow connected to a shared governance structure? So just all structural questions.
Well, when we started out, Chris, we had a sustainability committee, and it was a committee of master trainers that volunteered to be assigned to the TeamSTEPPS Action Councils. And they would join the council and help to get the council going and then continued to attend the meetings. And they would come back to our monthly sustainability meeting and report out on projects and barriers. And then we found that, well, this area is working on a very similar project, you know, where we could really be helping each other. So we created a SharePoint site on the hospital's intranet and started to log projects and progress on this SharePoint site. Our SharePoint site, our hospital intranet can be, it's a beast. It's pretty big, so it's hard to find things. So we knew that we needed to try to improve the communication in other ways. And as we gained more and more TeamSTEPPS Action Councils and the meeting got busier and busier, that's when we just recently started to do the briefing calls. We call them TeamSTEPPS Action Council briefing.
We also have
Yes, so also each TeamSTEPPS Action Council submits their minutes, and those are also posted on that hospital intranet, so that if one TAC is thinking about a project, they can look and see if another TAC is working on it and kind of put their heads together to make things easier.
And in a leadership way, what we do is we report out, I report out to the Chief Operating Officer, Chief Clinical Officer, regarding what we're doing with TeamSTEPPS Action Councils. And Annie is part of quality, and so quality also reports out to our board of directors for the hospital in terms of the projects that we work on. What's interesting is our TeamSTEPPS quality initiatives have been used during Joint Commission review when they have asked for what type of grassroots activities have you done, and we've been able to show them those things. Also, when nursing has gone for magnet, they wanted to know what interdisciplinary types of projects do we have within our organization, and we were able to show them the TeamSTEPPS quality projects that were underway.
Oh, that's great. Thank you. That was the next question I was going to ask, is how your TACs are working in the magnet structure. So thank you. Okay, so next question here. You know, we have about 3 minutes to go, so I think this is a nice closing question. And for everybody whose questions didn't get answered, we'll make sure to circle back with the Metro team to get them answered. But you know, if you think about this at the, you know, where you are in this journey, which is pretty far along, can you give us like the top three or the greatest hits of the key components that have really contributed to the longevity, you know, between administrative or financial or, you know, clinical outcomes, but what are the things that have really, really continued this moving forward at Metro for so long? How has it not gotten stale?
I'll just share what I have and then others can jump in, but the things that stand out for me is, number one, when we made our presentation to leadership, our CEO actually said to them, do you guys support this? And all the men and women in the room said, we think this is a great idea. And his response was, I'm glad to hear that, but now we have to take something off of our agenda for the coming year and get rid of that so that we can do TeamSTEPPS. He forced them to make a commitment to TeamSTEPPS, not just sort of say, oh, that sounds great, let's do it, but yes, we think it's good and we're going to do it instead of this other initiative that we had talked about doing. So I think their buy-in was key. The second thing I think was really key for us is we really did stick to the train-the-trainer model. So we did not go into an area with a group of people and train everyone, and the staff is looking at us going, who are you? I don't know who you are. I don't know why you're coming in here telling us how to do our job. Instead, instructors from that area did the training, so your colleague is talking to you about what we do day to day and how TeamSTEPPS can make it better. And I think that made a huge difference.
And I think the third thing would have to be our sustainability plan, because if you're going to train staff on the tools, you need to have opportunities for them to use the tools and see that they work. So the TeamSTEPPS Action Councils have been key. just bringing up TeamSTEPPS tools. Sometimes there's an action council that doesn't have a project at the present time, so they'll focus on a tool for a month. You know, and they'll get the information back out there, and they'll call it out when they see people using those tools. And I think keeping the information in front of people has helped to sustain it.
Well, thank you, and that's really good way, I think, to close this out. So we're at the top of the hour. I'd like to thank everybody that attended for spending time with us today. You received an evaluation in your email this morning. So if you could take a few moments to fill it out, that would be great. We really do look at your feedback and make sure that we tailor things in the future to meet what you've asked for. I'd like to really thank the 4 speakers from our friends at MetroHealth. Really appreciate you guys getting on the phone today. And for everybody that's listening, head on over to the website and see other opportunities there are for connecting with the MetroHealth team and other teams that we have in our faculty group. So with that, I'm going to wish you all a happy rest of your day, and to our friends in the Southeast, I hope everything goes okay in the next coming days with the hurricane approaching. So have a good afternoon, everybody.
Thank you.
Thanks, Chris.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.